Good day. I've already reviewed this topic in advance, but the video recording failed at the time, so I'm going to talk about acute coronary syndromes again. In a typical adult emergency room population with acute chest pain, about 15% of patients will have an acute coronary syndrome. ACS encompasses unstable angina through acute myocardial infarction. Of patients with an ACS, approximately one-third have an acute myocardial infarction and the remainder have unstable angina. The three principal presentations are rest angina, which occurs at rest and is prolonged usually for more than 20 minutes, new onset angina, which markedly limits ordinary physical activity, such as walking 1 to 2 blocks or climbing one flight of stairs or performing lighter activity, and increasing angina, which is a previously diagnosed angina that has become distinctly more frequent, has a longer duration, or is lower in threshold, limiting the ability to walk 1 to 2 blocks or climb one flight of stairs or perform lighter activity. These definitions assume that the anginal chest pain is due to ischemia, and it does not apply to patients presenting to the emergency room with chest pain from other causes. During the initial assessment, it may not be possible to determine whether the patient has or will sustain permanent damage to the myocardium, has reversible ischemia through injury or unstable angina, or has a non cardiac cause of symptoms. The American College of Cardiology and American Heart Association have a tool for estimating the short term risk of death or acute myocardial infarction in patients with unstable angina. We examine the history, the character of the pain, clinical findings, EKG, and cardiac markers. High likelihood for death or non fatal myocardial infarction includes the following features: an accelerating tempo of ischemic syndromes in the preceding 48 hours, prolonged, ongoing, that is, longer than 20 minutes of rest pain, pulmonary edema, most likely due to ischemia, new or worsening mitral regurgitation murmur, S3 or new or worsening rails, hypotension, bradycardia, tachycardia, age older than 75 years old, angina at rest with transient ST segment changes more than 0.5 millimeters, bundle branch block, new or presumed new, sustained ventricular tachycardia, elevated cardiac TNT, which is troponin T, troponin I, with TNT or TNI greater than zero point 0.1 nanogram per milliliter. Intermediate likelihood implies that the patient has no high risk feature, but they must have one of the following: a prior myocardial infarction, peripheral or cerebrovascular disease, or coronary artery bypass grafting and prior aspirin use, prolonged for more than 20 minutes rest angina, now resolved with moderate or high likelihood of CAD, rest angina or relieved with rest or sublingual nitroglycerin, nocturnal angina, new onset or progressive angina in the past 2 weeks without prolonged rest pain but with intermediate or high likelihood of CAD, an age older than 70 years old, T wave changes, pathologic Q waves, or resting ST depression less than 1 millimeter in multiple lead groups in the anterior, inferior, lateral, and slightly elevated cardiac troponin T and I, with troponin T more than zero point zero 0.01 but less than zero point 0.1 nanogram per ml. With low likelihood, this means that there are no high or intermediate risk features, but they may have any of the following: increased angina frequency, severity, or duration, angina provoked at a lower threshold, new onset angina with onset of 2 weeks to 2 months before presentation, chest discomfort reproduced by palpation, normal or unchanged EKG, and normal cardiac markers. So, when it comes to the anatomy of the heart, the left coronary artery divides into the left circumflex and the left anterior descending branches. The left anterior descending branch courses down the anterior aspect of the heart, providing the main blood supply to the anterior and septal regions of the heart. The circumflex branch supplies blood to some of the anterior wall and a large portion of the lateral. And the right coronary artery supplies the right side of the heart and provides some perfusion to the inferior aspect of the left ventricle through its continuation as the right posterior descending artery. The atrioventricular conduction system receives blood supply from the atrioventricular branch of the right coronary artery and the septal perforating branch of the left anterior descending coronary artery. Similarly, the right bundle branch and the posterior division of the left bundle branch each obtain blood flow from both the left anterior descending and right coronary arteries. The posterior medial papillary muscle receives blood supply from one coronary artery, usually the right coronary artery. Ischemia occurs when there's an imbalance between oxygen demand and oxygen supply. Oxygen supply is influenced by oxygen carrying capacity of the blood and coronary artery blood flow. The oxygen carrying capacity of the blood is determined by the amount of hemoglobin present and oxygen saturation. Coronary artery blood flow is determined by the duration of diastolic relaxation of the heart and peripheral vascular resistance. Humoral, neural, metabolic, and extravascular compressive forces and local autoregulation mechanisms determine the coronary vascular resistance. Exercise-induced myocardial ischemia and its sequelae usually occur as a result of fixed atherosclerotic lesions. ACS may be caused by secondary reduction in myocardial blood flow due to coronary arterial spasm, disruption or erosion of atherosclerotic plaques and platelet aggregation or thrombus formation at the site of an atherosclerotic lesion. Secondary causes of myocardial ischemia are less common and are prompted by factors extrinsic to the coronary arteries, such as increased myocardial oxygen demand through fever, tachycardia, or thyrotoxicosis, reduced blood flow in hypotension, or reduced oxygen delivery in anemia and hypoxemia. In the event of a secondary cause, global ischemia may occur widely or focally. Atherosclerotic plaque forms through repetitive injury to the vessel wall. Macrophages and smooth muscle cells are the main cellular elements in plaque development, whereas lipids are predominant in the extracellular milieu. Plaque fissuring and rupture are affected by features inherent to the plaque, such as its composition and shape, local factors such as shear forces, coronary arterial tone, and coronary arterial perfusion pressure, and movements of the artery in response to myocardial contractions. When plaque rupture occurs, potent thrombogenic substances activate circulating platelets. The platelet response involves adhesion, activation, and aggregation. Platelet adhesion occurs through the weak platelet interactions with subendothelial adhesion molecules such as collagen, fibronectin, and laminin, and the binding of the glycoprotein 2B receptor to the subendothelial form of von Willebrand factor. Adherent platelets are strongly thrombogenic. Lipid-laden macrophages in the plaque core and adventitia of the vessel wall release tissue factor, which stimulates the conversion of prothrombin to thrombin. Thrombin and the local shear forces are also potent platelet activators. Platelet secretion of adenosine diphosphate, thromboxane A2, and serotonin are autostimulatory agonists of platelet activation. Activated platelet glycoprotein 2B3A receptors become cross-linked by fibrinogen or von Willebrand factor in the common pathway of platelet aggregation. The extent of oxygen deprivation and the clinical presentation of ACS depend on the limitation of oxygen delivery imposed by thrombus adhering to a plaque. In stable angina, ischemia occurs only when activity induces oxygen demands beyond the supply restrictions imposed by a partially occluded coronary vessel. Ischemia occurs at a relatively fixed point and changes slowly over time. In this scenario, the atherosclerotic plaque has not ruptured and there is little or no superimposed thrombus. In acute coronary syndrome, atherosclerotic plaque rupture and platelet-rich thrombus develop. Coronary blood flow is reduced suddenly and myocardial ischemia occurs. The degree and duration of the oxygen supply-demand mismatch determines whether the patient develops reversible myocardial ischemia without necrosis, also known as unstable angina, or myocardial ischemia with necrosis or AMI. More severe and prolonged obstruction increases the likelihood of infarction. An acute myocardial infarction may inhibit myocardial contractility and impair both central and peripheral perfusion. When an area of the myocardium does not receive adequate oxygen, the functional deterioration progresses. As the size of the infarcted myocardium increases, left ventricular pump function decreases. This creates increased left ventricular and diastolic pressure and end systolic volume. Cardiac output, stroke volume, and blood pressure may decrease. When left atrial and pulmonary capillary pressures increase, heart failure or pulmonary edema may develop. Poor perfusion to the brain and kidneys can result in altered mental status and impaired renal function, respectively. The main symptom of ischemic heart disease is chest discomfort or pain, and the history should characterize its severity, location, radiation, duration, and quality. In addition, the presence of associated symptoms such as nausea, vomiting, diaphoresis, dyspnea, lightheadedness, syncope, and palpitations may help detect myocardial ischemia. Symptoms of acute myocardial ischemia often will be described as discomfort rather than pain. We look for descriptions of chest pressure, heaviness, tightness, fullness, or squeezing. Less commonly, patients will describe their symptoms as knife-like, sharp, or stabbing. The classic pain or discomfort location is substernal or in the left chest, with radiation to either arm, neck, or jaw. Reproducible chest wall tenderness is noted in some. Exercise, stress, and a cold environment classically precipitate angina. Angina typically has a duration of symptoms of less than 10 minutes, occasionally lasting up to 10 to 20 minutes, and usually improves within 2 to 5 minutes after rest or nitroglycerin. In contrast, acute myocardial ischemia is usually accompanied by more prolonged and severe chest discomfort, more prominent associated symptoms such as nausea, diaphoresis, and shortness of breath, and little response to initial sublingual nitroglycerin. Easy fatigability may be a prominent symptom of ACS, especially in women. Ask about the frequency of anginal episodes and any change in frequency of episodes over the past months. Determine if there is any increase in severity or duration of symptoms, or whether less effort is required to precipitate symptoms. Advanced age, female gender, and a history of diabetes mellitus are associated with more non-classic ACS presentations. Presentations with non-classic features or silent myocardial ischemia are common, for example, for as many as 37.5% of women and 27.4% of men present without chest pain. Up to 30% of patients with acute myocardial ischemia are clinically unrecognized, often not seeking medical care or not recalling any symptoms. The prognosis for patients with non-classic symptoms like fatigue, weakness, not feeling well, and vague discomfort at the time of infarction is worse than that of patients with more classic symptoms, probably because of the difficulty of getting to the right diagnosis. Women and the elderly are likely to have presentations that differ from classic ones in the younger patients. Across all age groups, those with unstable angina have non-classic features nearly half of the time. This is why the term atypical chest pain is misleading because non-classic presentations are common despite being called atypical. Cardiac risk factors are poor predictors of risk for AMI or other acute coronary syndromes. Traditional cardiac risk factors for CAD, such as hypertension, diabetes mellitus, tobacco use, family history at an early age, and hypercholesterolemia are not helpful to predict ACS in emergency patients older than 40 years old. The cardiac risk factors predict the risk of CAD over time, not the likelihood of presence at one moment. Patients with acute coronary syndromes may appear well without any clinical signs of distress or may be uncomfortable, pale, cyanotic, or in respiratory distress. The pulse rate may be normal or display bradycardia, tachycardia, or irregular pulses. Bradycardic rhythms are more common with inferior wall myocardial ischemia. In the setting of an acute anterior wall infarction, bradycardia or new heart block is a poor prognostic sign. Blood pressure can be normal, elevated due to baseline hypertension, sympathetic stimulation, and anxiety, or decreased due to pump failure or inadequate preload, although extremes of blood pressure are associated with a worse prognosis. An S3 is present in 15 to 20% of patients with acute myocardial infarction. If detected, an S3 may indicate a failing myocardium. The presence of new systolic murmur is an ominous sign because it may signify papillary muscle dysfunction, a flail leaflet of the mitral valve with resultant mitral regurgitation, or a ventricular septal defect. The presence of rales with or without an S3 gallop indicates left ventricular dysfunction and left-sided heart failure. Jugular venous distension, hepatojugular reflex, and peripheral edema suggest right-sided heart failure. The diagnosis of ST segment elevation myocardial infarction depends on the EKG in the setting of symptoms suggestive of myocardial infarction. The diagnosis of non-ST segment elevation myocardial infarction depends on abnormal elevation of cardiac biomarkers but may include EKG changes not meeting criteria for STEMI. The diagnosis of unstable angina is based on history because the EKG and cardiac injury biomarkers are non-diagnostic. Early risk assessment for the likelihood of myocardial infarction uses all of these data to aid decision making. The likelihood that signs and symptoms represent acute coronary syndrome secondary to coronary artery disease are grouped into high likelihood, intermediate likelihood, and low likelihood. So we look at the history, we look at the examination results, EKG, and cardiac markers. There's a high likelihood if there's any of the following: chest or left arm pain or discomfort as a chief symptom reproducing prior documented angina, known history of coronary artery disease including myocardial infarction, transient mitral regurgitation murmurs, hypotension, diaphoresis, pulmonary edema, or rales. New or presumably new transient ST segment deviation more than or equal to 1 millimeter, or T-wave inversion in multiple precordial leads. Elevated cardiac troponin I, troponin T, or MB fraction of creatine kinase. Again, we have to remember that creatine kinase, even the MB fraction, is not specific for myocardial infarction. Intermediate likelihood is ascribed to the absence of high likelihood features and the presence of any of the following: chest or left arm pain or discomfort as the chief symptom, age older than 70 years old, male gender, diabetes mellitus, extracardiac vascular disease, fixed Q waves, ST depression, zero point 0.5 to 1.0 millimeters, or T wave inversion greater than 1 millimeter, and normal cardiac markers. There's a low likelihood if there's an absence of higher intermediate likelihood features, but they may have the following: such as probable ischemic symptoms in absence of any of the intermediate likelihood characteristics, recent cocaine use, chest discomfort reproduced by palpation, T-wave flattening or inversion, less than 1 millimeter in leads with dominant R waves, normal EKG, and normal cardiac markers. Thrombosis in myocardial infarction, or the TIMI score for unstable angina, is composed of the following. The presence of each of the following is assigned 1 point. The maximum possible score is 7. Age 65 years or older, 3 or more traditional risk factors for coronary artery disease, prior coronary stenosis of 50% or more, ST segment deviation on presenting electrocardiogram, 2 or more anginal events in the prior 24 hours, aspirin use within 7 days prior to presentation, elevated cardiac markers, and as mentioned earlier, the presence of each of the above is assigned 1 point, and the maximum possible score is 7. This thrombosis in myocardial infarction score is a 7-item tool that helps stratify patients with potential ACS in the emergency room. Patients with a score of 0 to 2 have a 2 to 9% 30-day risk of death, myocardial infarction, or revascularization. Patients with higher scores, of course, have higher risks. The standard 12-lead EKG is the single best test, although it can be fallible, to identify patients with acute myocardial infarction upon emergency presentation. We obtain the initial 12-lead ECG and interpret the tracing quickly, ideally within 10 minutes of presentation, in patients with symptoms suggestive of myocardial ischemia. Pre-hospital EKGs reduce the time from symptom onset to reperfusion therapy in STEMI patients and are an optimal tool when possible. ST segment-based diagnostic EKG criteria are as follows. If there is an anteroseptal location of ST segment elevation, you would see ST segment elevations in V1, V2, and possibly V3. For the anterior location, there are elevations in V1, V2, V3, and V4. Anterolateral has elevations in V1 to V6, lead 1, and AVL. Lateral shows elevations in 1 and AVL. Inferior shows elevations in 2, 3, and AVF. Inferolateral shows elevations in 2, 3, AVF, V5, and V6. True posterior shows R waves in V1 and V2 more than 0.4, more than 0.04 seconds, and an RS ratio of greater than or equal to 1. Posterior wall infarction does not produce Q-wave abnormalities in conventional leads and is diagnosed in the presence of tall R waves in V1 and V2. And right ventricular involves ST segment elevations in 2, 3, AVF, and ST elevation in the right side V4. STEMI in the listed distribution suggests acute transmural injury. ST segment depressions in these distributions suggest ischemia. inferior wall acute myocardial infarction should have a right-sided lead V4 obtained because ST segment elevation in V4R is highly suggestive of right ventricular infarction. For patients with a non-diagnostic tracing and persistent symptoms with a high risk of ACS, we repeat the EKG to detect developing changes. Early studies of fibrinolytic therapy identified an increased risk of mortality in patients with new bundle branch block, which led to interpreting a left bundle branch block that is new as being a STEMI equivalent. However, less than 10% of patients with new or possibly new left bundle branch block have acute myocardial infarction. Reciprocal ST segment changes, those in leads away from or opposite the elevation area, are from subendocardial ischemia and denote a larger area of injury risk, an increased severity of underlying CAD, more severe pump failure, a higher likelihood of cardiovascular complications, and increased mortality. In general, the more elevated the ST segments and the more ST segments that are elevated, the more extensive is the injury. The EKG changes correlate well with the infarct-related vessel, and inferior wall acute myocardial infarctions can result from occlusion of the left circumflex artery or the right coronary artery. In the setting of an inferior wall AMI, ST segment elevation in at least one lateral lead, V5, V6, or AVL, with an isoelectric or elevated ST segment in lead 1 is strongly suggestive of a left circumflex lesion. The presence of an ST segment elevation in lead 3 greater than that in lead 2 predicts a right coronary artery occlusion. When accompanied by ST segment elevation in V1 or a V4R, it predicts a proximal right coronary artery lesion with accompanying right ventricular infarction. Reciprocal anterior ST segment depressions in V1 through V4 are equally prevalent in right coronary and left circumflex inferior wall AMIs. So when it comes to EKG findings and the culprit coronary artery, for EKG findings for inferior ST segment elevation myocardial infarction, if there is ST segment elevation in lead 3 greater than in lead 2 plus ST segment depression of more than 1 mm in lead 1, lead AVL, or both, the culprit artery is the right coronary artery. And in addition to the findings previously mentioned, if there's an ST segment elevation in V1, V4R, or both, the culprit artery is the proximal right coronary artery. If there's absence of the findings that I mentioned and ST segment elevation in leads 1, AVL, V5, and V6, and ST segment depression in leads V1, V2, and V3, the culprit artery is the left circumflex coronary artery. For anterior ST segment elevation myocardial infarction, ST segment elevations in leads V1, V2, and V3 plus any of the features below. For proximal left anterior descending coronary artery, this would be ST segment elevation of more than 2.5 mm in lead V1 or right bundle branch block with Q wave or both. For proximal left anterior descending coronary artery as well, you also have an ST segment depression of more than 1 mm in leads 2, 3, and AVF. And for the distal left anterior descending coronary artery, you have ST segment depression of less than or equal to 1 mm or ST segment elevation in leads 2, 3, and AVF. EKGs are frequently misinterpreted, with a low of 5.9% to as many as 29% being misinterpreted. False positive interpretations of the EKG indicating STEMI when no injury exists occur between 11 and 14% of the time. Balancing this is the observation that even patients with normal or non-specific EKGs have a 1 to 5% incidence of acute myocardial infarction and a 4 to 23% incidence of unstable angina. Patients with non-diagnostic EKGs or evidence of ischemia that is age indeterminate have a 4 to 7% incidence of acute myocardial infarction and a 21 to 48% incidence of unstable angina. Demonstration of new ischemia in EKG increases the risk of acute myocardial infarction from 25% to 73% and the unstable angina risk from 14% to 43%. Thus, the standard 12-lead EKG is useful for cardiovascular risk stratification of patients with acute coronary syndromes. The only guideline recommended addition to the standard 12-lead EKG is the use of right-sided precordial lead in the setting of acute inferior myocardial infarction to detect right ventricular involvement. There are several clinical conditions in which EKG interpretation is difficult. In the setting of paced rhythms or left bundle branch block, acute myocardial ischemia can be identified with select findings. In those with a pre-existing left bundle branch block, the following patterns are indicative of acute myocardial infarction. ST segment elevation of 1 mm or greater and concordant, which means in the same direction as the main deflection, with a QRS complex. ST segment depression of 1 mm or more in leads V1, V2, or V3. ST segment elevation of 5 mm or greater and discordant or in the opposite direction with the QRS complex. And right ventricular pacing, the common pacemaker lead location, causes secondary repolarization changes of opposing polarity to that of the predominant QRS complex. Most leads have predominant negative QRS complexes followed by ST segment elevation and positive T waves. ST segment elevation of at least 5 mm is most indicative of acute myocardial infarction in leads with predominantly negative QRS complexes. Any ST segment elevation concordant to the QRS complex in a predominantly positive QRS complex is highly specific for AMI. The QRS complex is predominantly negative in leads V1 to V3 with right ventricular pacing. ST segment depression in these leads has 80% specificity for AMI. Patients with diagnostic ST segment elevation on their initial EKG do not require serum marker measurement to make treatment and disposition decisions. Conversely, serum markers are useful in patients with non-diagnostic EKGs for diagnosis of NSTEMI and risk stratification of patients with STEMI, NSTEMI, and unstable angina. Even low-level cardiac marker elevations are independent risk factors for acute or less than 30 days cardiac complications and short-term or less than 1 year prognosis in unstable angina. A rise in serum troponin I or troponin T with at least one value above the 99th percentile is diagnostic for AMI in patients with symptoms consistent with ACS. Low-level elevations in either troponin correlate with risk for cardiovascular complications in unstable angina, CAD, and renal failure. Troponin is sensitive and specific for cardiac myocardial necrosis, but there are many causes of myocardial necrosis unrelated to acute coronary syndrome. Minor elevations in cardiac troponin I and cardiac troponin T elevate or rather identify patients more likely to benefit from treatment with glycoprotein 2B, 3A inhibitors, enoxaparin, and early invasive treatment strategy, which is catheterization within 24 to 48 hours. New high-sensitivity cardiac troponins have improved ability to detect ischemia. First-generation single assays of cardiac troponin I at the time of presentation had an acute myocardial infarction sensitivity of 39%. Serial sampling increased sensitivity to 90 to 100% with a specificity of 83 to 96% for cardiac troponin I and 76% to 91% for cardiac troponin T. The high-sensitivity troponins initially used in Europe identify 90 to 100% of patients with acute myocardial infarct at the time of arrival using the lowest cut point, albeit with limited specificity. So, conditions in which EKG interpretation can be difficult include those where patients may have ST segment elevation in the absence of acute myocardial infarction, such as early repolarization, left ventricular hypertrophy, pericarditis, myocarditis, left ventricular aneurysm, hypertrophic cardiomyopathy, hypothermia, ventricular paced rhythms, left bundle branch block. In conditions with ST segment depressions in the absence of ischemia, such as hypokalemia, digoxin effect, cor pulmonale, and right heart strain, early repolarization, left ventricular hypertrophy, ventricular paced rhythms, and left bundle branch block. There are also conditions where there may be T-wave inversions in the absence of ischemia. These include persistent juvenile pattern, Stokes-Adams syncope or seizures, post-tachycardia T-wave inversion, post-pacemaker T-wave inversion, intracranial pathology such as CNS hemorrhage, mitral valve prolapse, pericarditis, primary or secondary myocardial diseases, pulmonary embolism or cor pulmonale from other causes, spontaneous pneumothorax, myocardial contusion, left ventricular hypertrophy, ventricular paced rhythms, left bundle branch block, and right bundle branch block. Despite the new sensitive assays, guidelines and experts recommend serial troponin testing to identify acute disease. A serial high-sensitivity troponin interval as short as 2 hours coupled with a low TMI risk score with less than 2 virtually excludes acute myocardial infarction. The European Society of Cardiology recommends a 3-hour serial interval when high-sensitivity troponins are used. Elevated levels of the cardiac troponins in patients with NSTEMI increase the short-term risk of death 3.1-fold. Although patients with elevated troponins in the absence of ACS may be false positives for AMI, elevated troponin of any amount is associated with a high frequency of worse outcomes. Taken together, the data strongly support the claim that any measurable elevated troponin is always worse than no elevated troponin, and that more troponin elevation is always worse than less troponin elevation with respect to prognosis. B-type natriuretic peptide, an established marker for patients with heart failure, is also elevated in patients with acute coronary syndrome and can identify acute coronary syndrome patients who are at higher risk for adverse cardiovascular events, heart failure, or death. When used in conjunction with other markers, the addition of B-type natriuretic peptide increases sensitivity at the cost of decreased specificity, with only a slight increase in overall diagnostic accuracy. The treatment of ACS is based on duration and persistence of symptoms, cardiac history, and findings on physical examination and the initial EKG. We establish IV access, give aspirin if not already given, and as long as there are no contraindications, we provide EKG monitoring. Many recommend supplemental oxygen. However, there's little evidence for benefit in patients without hypoxemia, and small studies have shown a negative effect with high-flow oxygen. The key treatment strategies aim to achieve immediate reperfusion and limit infarct size. So when it comes to drugs used in the emergency treatment of ST elevation, myocardial infarction, we have aspirin at 162 to 325 milligrams. We have clopidogrel, prasugrel, and ticagrelor. Antithrombins include unfractionated heparin with a bolus of 60 units per kilogram with a maximum of 4,000 units, followed by an infusion of 12 units per kilogram per hour with a maximum of 1,000 units per hour, titrated to a partial thromboplastin time 1.5 to 2.5 times control. Enoxaparin and fondaparinux are also given. Fibrinolytic agents include streptokinase at 1.5 million units over 60 minutes, anistreptase at 30 units IV over 2 to 5 minutes, and altiplase, which differs in the dose depending on body weight. If body weight is over 67 kilograms, you give 15 milligrams initial IV bolus, 50 milligrams infused over the next 30 minutes, and 35 milligrams infused over the next 60 minutes. If the body weight is less than 67 kilograms, we give a 15 milligram initial IV bolus, 0.75 milligram per kilogram infused over the next 30 minutes, and 0.5 milligram per kilogram infused over the next 60 minutes. Redaplase and tenecteplase are also other fibrinolytic agents that we give. Glycoprotein 2B3A inhibitors include abscizumab, eptifibatide, and tirofiban. Other anti-ischemic therapies include nitroglycerin, either sublingually or intravenously, morphine, metoprolol, and atenolol. Drugs that are used in the emergency treatment of unstable angina or NSTEMI also include aspirin with the same dose as earlier, clopidogrel, prasugrel, ticagrelor, antithrombin such as heparin, enoxaparin, fondaparinux, direct thrombin inhibitors such as bivalirudin, glycoprotein 2B3A inhibitors such as abscizumab, eptifibatide, and tirofiban, and other anti-ischemic therapies such as nitroglycerin, metoprolol, and atenolol. So, when it comes to percutaneous coronary intervention, the American College of Cardiology, the American Heart Association, and the European Society of Cardiology recommend PCI as the preferred method of reperfusion therapy if the first medical contact to first balloon inflation time is less than 90 to 120 minutes. Coronary angioplasty with or without stent placement is the most common type of percutaneous coronary intervention, and alternatives include atherectomy and laser angioplasty. Balloon angioplasty increases the size of the arterial lumen through endothelial denudation, cracking, splitting, and disruption of atherosclerotic plaque, dehiscence of the intima and plaque from underlying media, and stretching or tearing of underlying media and adventitia. With successful dilation, small amounts of arterial wall dissection and aneurysmal expansion may be seen. The greater the increase in luminal size, the lower is the risk of restenosis. However, more aggressive balloon inflation can augment dissection, platelet deposition, thrombus formation, and plaque hemorrhage. Alternative PCI procedures attempt to limit complications. Directional and rotational coronary atherectomy extract atherosclerotic tissue from the coronary artery. Excimer laser atherectomy vaporizes atheromatous tissue. It results in larger luminal diameters but has not reduced rates of restenosis or other complications associated with percutaneous angioplasty procedures. Coronary stents are fenestrated stainless steel tubes that are expanded by a balloon to provide scaffolding within the coronary arteries. Adding antiplatelet therapy, in particular thienopyridines and glycoprotein 2b3A inhibitors, results in lower adverse events at 6 months. Drug-eluting stents are associated with decreased early vessel closure, but a higher delayed closure, particularly once antiplatelet agents such as clopidogrel are stopped. In centers with expertise in direct angioplasty, primary PCI reduces the cardiovascular complication rate in patients with AMI compared to fibrinolysis. The longer the duration of symptoms, the greater is the benefit to primary PCI over fibrinolysis. PCI is more effective in establishing flow and reducing reocclusion in the infarct-related artery than fibrinolytic therapy, and is associated with a decreased incidence of short and long-term death, non-fatal reinfarction, and intracranial hemorrhage compared with fibrinolytic therapy. So when it comes to fibrinolytic therapy, fibrinolytic agents such as tissue plasminogen activator, recombinant tissue plasminogen activator, tenecteplase, streptokinase, and anistreptase act on the acute thrombosis directly or indirectly as plasminogen activators. Plasminogen, an inactive proteolytic enzyme, binds directly to fibrin during thrombus formation to form a plasminogen fibrin complex. This plasminogen fibrin complex incorporated into the clot is more susceptible than circulating plasma plasminogen to activation. Thus, the concept that fibrinolytic agents are to a varying degree clot-specific, promoting fibrin proteolysis. Fibrinolytic therapy improves left ventricular function and short-term and long-term mortality. It is indicated for patients with STEMI as a reperfusion option if time to treatment is less than 6 to 12 hours from symptom onset and the EKG has at least 1 millimeter of ST segment elevation in 2 or more contiguous leads. Therapy is more beneficial if given early and for larger infarctions and anterior infarctions than for smaller or inferior infarctions. In the elderly, the overall risk of mortality from acute myocardial infarction is high. The proportionate reduction in mortality rate appears to be less in patients older than 75 years old, but the absolute number of patients who may be saved is still considerable. After failed fibrinolytic administration, rescue PCI is recommended for patients in cardiogenic shock who are less than 75 years old, patients with severe heart failure or pulmonary edema, patients with hemodynamically compromising ventricular arrhythmias, and patients in whom fibrinolytic therapy has failed and a moderate or large area of myocardium is at risk. Because tissue plasminogen activator, recombinant tissue plasminogen activator, and tenecteplase have similar efficacy and safety profiles, the choice of which to use is usually based on ease of administration, cost, and local preferences. There are contraindications to fibrinolytic therapy in ST segment elevation myocardial infarction. These include the following absolute contraindications: any prior intracranial hemorrhage, known structural cerebral vascular lesions such as arteriovenous malformations, known intracranial neoplasm, ischemic stroke within the last 3 months, acute internal bleeding excluding menses, suspected aortic dissection or pericarditis, and the following relative contraindications: severe uncontrolled blood pressure of greater than 180 over 100 millimeters mercury, history of chronic, severe, poorly controlled hypertension, history of prior ischemic stroke more than 3 months, or known intracranial pathology not covered in the contraindications, current use of anticoagulants with a known INR of greater than 2 to 3, known bleeding diathesis, recent trauma in the past 2 weeks, prolonged CPR for more than 10 minutes, major surgery in the last 3 weeks, non-compressible vascular punctures including subclavian and internal jugular central lines, recent internal bleeding within 2 to 4 weeks, patients treated previously with streptokinase because they should not receive streptokinase a second time, pregnancy, active peptic ulcer disease, and other medical conditions likely to increase the risk of bleeding, such as diabetic retinopathy. The glycoprotein 2b3A antagonists are stronger antiplatelet agents than aspirin, interrupting platelet activation regardless of the agonist. In contrast, aspirin only inhibits platelet aggregation stimulated through thromboxane A2 and mediated through the arachidonic acid pathway. So when it comes to ADP receptor antagonists, we have prasugrel and ticagrelor. Prasugrel is an irreversible potent platelet receptor antagonist in this class. The U.S. Food and Drug Administration, however, issued a boxed warning for prasugrel, indicating that use is contraindicated in patients with a previous cerebrovascular accident or transient ischemic attack or with pathologic bleeding. Additional risk factors for bleeding are age older than or equal to 75 years, propensity for bleeding, and concomitant use of medications that increase the risk of bleeding. Ticagrelor, on the other hand, is a reversible non-thienopyridine P2Y12 receptor antagonist with the effect gone within 3 days of stopping the agent. The addition of clopidogrel to aspirin and antithrombin therapy improves cardiovascular outcomes in patients receiving fibrinolysis for STEMI, as demonstrated in the Clarity PIMI-28 trial and the COMET trial. We give clopidogrel to patients with true aspirin allergy. Early administration is recommended in patients with ACS regardless of whether non-invasive management or PCI is planned. For patients undergoing urgent PCI, 600 mg is superior to 300 mg in preventing post-procedure myocardial infarction. So when it comes to the glycoprotein 2B2A inhibitors, abscizumab is a chimeric antibody that binds irreversibly to the glycoprotein 2B3A antagonists. The duration of action is longer than that of smaller peptide molecules. Eptifibatide is a synthetic heptapeptide that binds reversibly to the glycoprotein 2B2A receptor. Abscizumab is a chimeric antibody that binds irreversibly to the glycoprotein 2B2A receptors. Eptifibatide is a synthetic heptapeptide that binds reversibly to the same receptor, and tirofiban is a synthetic small molecule with reversible binding as well. All of these require an IV infusion to demonstrate sustained benefits. Reversal of platelet inhibition after cessation of infusion is more rapid with the polypeptide or small molecule agents eptifibatide or tirofiban, an advantage when bleeding complications occur. When it comes to antithrombins, unfractionated heparin reduces the risk of AMI and death during the acute phase of unstable angina. The combination therapy of aspirin and heparin reduces the short-term risk of death or AMI. Thus, combination therapy with aspirin and heparin is indicated for patients with ACS. It does have an unpredictable anticoagulant response, however, because the bioavailability of heparin is variable. So this is why we need to constantly monitor coagulation factors and rather coagulation parameters in these patients, especially APTT. The low molecular weight heparins have greater bioavailability, lower protein binding, and a longer half-life, and achieve a more reliable anticoagulant effect. As a result, they are given in a fixed dose subcutaneously once or twice a day and achieve a stable therapeutic response without the need for monitoring anticoagulation. However, enoxaparin is not considered a first-line antithrombin for patients receiving primary PCI for the treatment of STEMI. But in the event that the patient previously started on enoxaparin goes for PCI, it should be continued. Fondaparinux is not a monotherapy for PCI, and if used, we have to add unfractionated heparin or bivalirudin before PCI. It is a synthetic pentasaccharide that binds to antithrombin 3 to form an antithrombic complex, but unlike heparin, this complex is very specific for factor 10A inhibition. And we also have bivalirudin, which is a direct thrombin inhibitor. It binds to the catalytic site of thrombin, binds to thrombin in clot, and it is resistant to agents that degrade heparin. And when it comes to limiting the infarct size, we have nitrates. In acute myocardial infarction, we titrate IV nitroglycerin to blood pressure reduction rather than to symptom or chest pain resolution. We also use nitroglycerin cautiously for patients with inferior wall ischemia because 1/3 of such patients might have right ventricular involvement and hence are volume dependent. Nitrates reduce preload and commonly trigger hypotension in this setting, worsening infarct. If nitroglycerin results in hypotension, we stop the drug and administer fluid for blood pressure. We avoid nitrates in patients with ACS who recently received a phosphodiesterase inhibitor for erectile dysfunction within 24 hours of sildenafil use or within 48 hours of tadalafil use. Beta-Adrenergic Antagonists have antidysrhythmic, anti-ischemic, and antihypertensive properties. During acute myocardial infarction, they diminish myocardial oxygen demand by decreasing heart rate, systemic arterial pressure, and myocardial contractility. Metoprolol reduced the absolute risks of reinfarction by 5 per 1,000 and of ventricular fibrillation by 5 per 1,000, but importantly, it increased the risk of cardiogenic shock by 11 per 1,000. The American College of Cardiology and American Heart Association recommendations are to start per orem, not IV, beta antagonists in patients with STEMI or NSTEMI within 24 hours, provided that the patient has no signs of heart failure, no evidence of a low cardiac output state, no risk for cardiogenic shock, which is an age of more than 70 years old, systolic blood pressure of less than 120 millimeters mercury, sinus tachycardia of greater than 110 beats per minute, or bradycardia less than 60 beats per minute, and longer duration of STEMI symptoms before diagnosis and treatment, or a patient without any standard relative contraindications to beta blockade, such as a PR interval of more than 0.24 seconds, second or third degree heart block, active asthma, or reactive airway disease. IV therapy is reserved for patients with significant hypertension. Angiotensin converting enzyme inhibitors reduce left ventricular dysfunction and left ventricular dilatation through stopping cardiac remodeling and slows the development of congestive heart failure during acute myocardial infarction. It's not usually given in the emergency setting. Magnesium produces systemic and coronary vasodilation, possesses antiplatelet activity, suppresses automaticity, and protects myocytes from calcium influx during reperfusion. However, studies are conflicting, and some found that the mortality rate is reduced and others show no benefit at all. Calcium antagonists, on the other hand, do not reduce mortality rate after acute myocardial infarction, and they may be harmful to some patients with cardiovascular disease. And the following are the complications of acute coronary syndrome. You can have dysrhythmias and conduction disturbances, and you can also have among the sinus tachycardia, atrial fibrillation, sinus bradycardia, and a complete heart block. You can also have heart failure, and some 15 to 20% of patients with acute myocardial infarction present with some degree of heart failure. One-third of these patients also have circulatory shock. There could also be mechanical complications due to tearing or rupture of infarcted tissue, such as ventricular free wall rupture, rupture of the interventricular septum, and papillary muscle rupture. You can also have pericarditis. Early post-AMI pericarditis occurs in less than 5% of patients since we now have PCI intervention. The pain of pericarditis can be confused with that of infarct extension or post-AMI angina. Classically, the discomfort of pericarditis becomes worse with a deep inspiration and may be relieved by sitting forward. There could also be right ventricular infarction, although this is extremely rare and is usually seen as a complication of inferior infarction. The most serious complication of right ventricular infarction is shock. The severity of the hemodynamic derangement in the setting of right ventricular infarction is related to the extent of right ventricular dysfunction, the interaction between the ventricles, such as the right and left ventricles since they share the interventricular septum, and the interaction between the pericardium and the right ventricle. In the setting of right ventricular infarction, nitrates often will reduce cardiac output and produce hypotension. If cardiac output is not improved after 1 to 2 liters of normal saline, we begin inotropic support with dobutamine. Other complications of AMI that occur but are not usually seen in the emergency room include left ventricular thrombus formation, arterial embolization, venous thrombosis, pulmonary embolism, post-infarction angina, and infarct extension. So there could also be recurrent or refractory ischemia, and an intra-aortic balloon pump may be used, especially if the patient is hemodynamically unstable and emergent catheterization is not available. The net effect of intra-aortic balloon counterpulsation is an increase in cardiac output, reduction in systolic arterial pressure, increase in diastolic arterial pressure, little change in mean arterial pressure, and reduction in heart rate. The reduction in left ventricular afterload leads to reduced myocardial oxygen consumption, thereby decreasing the amount of myocardial ischemia. Intra-aortic balloon counterpulsation is recommended for patients with ACS who are refractory to aggressive medical management or are hemodynamically unstable as a means to bridge patient stability and route to definitive treatment. Our source is Tintinalli's Emergency Medicine. Thank you.